Staying with us, you're watching NTV Tonight as we have a conversation with Dr. Brian Lishenga, the chairperson of the Rural Urban Private Hospitals Association of Kenya, or RUPHA as you may call it. Dr. Lishenga, there is a growing concern and tensions within the health sector in the country. You know, stakeholders continue to grapple with the transition from NHIF to SHIF. From where you stand as chairperson of RUPHA, where does the problem lie?
Okay, so thank you for having me. So we have a couple of problems. Well, one is the issue of payments to providers. As you are aware, when we passed the law, SHA inherited all the liabilities of NHIF, as well as the assets. So one of the things that worries us is the posture by SHA that the mess of NHIF cannot be transmitted to SHA. What I mean is this. It is pretentious to inherit the cups, the spoons, and the vehicles and say then those are good things, including the buildings. But then when it comes to the liabilities, you say, no, wait. We have a pending bills committee, you know, these are being... So the first problem is that healthcare provider liability has not been treated with the urgency that it deserves. So what is happening as a result? You have quite a number of hospitals that are in financial distress. And this is just not only RUPHA members. Right. This is also public hospitals, faith-based hospitals. There's a lot of distress because most providers, and we did in our survey recently, we asked them, if you had a choice, what would you rather that SHA paid? Would you rather that SHA paid NHIF arrears? Or rather, we even gave a middle way. We said combined, a little bit of SHA, a little bit of NHIF arrears, or SHA only. And overwhelmingly, what providers told us is that 72%, they want NHIF arrears to be sorted out, 72% of them. So when we dig deeper here, what we find is that they have a lot of exposure from banks, from suppliers, from their employees on past arrears. Something else very interesting is happening. We looked at the Transitional Committee report, the committee that was gazetted by the former CS. And we found out that 2.7 million claims, NHIF claims, were unreconciled. In other words, what they knew as at August, what they knew for sure they should pay is 15.8 billion. But they had almost 2.7 million claims hanging somewhere that they are not aware of. In our own estimate, those 2.7 million claims are worth another 14 billion shillings. The
unverified claims, that is.
Unverified claims.
Right.
Now, we have a major problem here. SHA rather, is involved currently in a process of retrenching and sending home the former NHIF. We know this is in the public domain. People have been asked to reapply for jobs. People have been told you might be redeployed, or if you want a golden handshake to go home, you'll be retired. What we worry is that the institutional memory that is required to reconcile that 14 billion shillings claims is going to be sent home. So you have SHA officers, former NHIF employees in branches in Nakuru, in Naivasha, in Narok, wherever, who today, as we are seated here, are not having job security. These are the people we as providers have to deal with every day if we have reconciliation issues. Now, even worse, the NHIF portal where we used to put our claims, we don't have access. So if an error happened somewhere in SHA towers and that data disappeared, we're looking at healthcare providers just basically flat-footed. So that's the first primary problem. Second one is the transition itself has been mismanaged. If you look at patient registration, our survey shows that the reason why out-of-pocket payment is going up is 44% of Kenyans are saying, 44% of facilities are telling us is because Kenyans are not registered. That's number one. So when they come to hospital, so why are Kenyans not registered? We ask the same question. Guess what? They are not registered because the process requires either access to internet or access to a phone. And there are places in Kenya, especially rural communities which we represent, where people don't have phones, people don't have access to internet. Now, again, if you do have a phone, the process requires you to use a one-time PIN, which is sent from somewhere, I don't know where it comes from, before you can continue. We have situations where a whole day, literally a whole day across Kenya, OTPs or one-time pins are not coming in, we can't register people. Patients waiting for surgeries, they require the same one-time pin. They are waiting. We have cases, people have an accident, somebody has an accident on Friday, Thursday the following week, still hasn't had surgery. What are they waiting for? Pre-authorization. So we are saying as hospitals, we want to provide care, but we must be empowered to provide care. You must give us finances, one. You must give us a portal that is stable, two. And you must reconcile historical debt.
You talked about 29 billion shillings owed to you by the defunct NHIF.
Yes.
That is the amount of money.
Yes.
Why do you believe the government has not been able to reconcile these debts up until now?
So this is one of the things that makes us really sad, because you see, we have had a narrative going on over the last few months that NHIF was bad, NHIF was corrupt, everyone was stealing from NHIF. The providers were stealing, and anyone who says any criticism of SHA is a beneficiary of the corruption of NHIF. This is not the reality. Just to set the record straight, what really killed NHIF, what killed NHIF was not Kenyans. It was ministries, departments, and agencies, state corporations, which deducted NHIF premiums from the pay slips of their employees and never remitted it. So you have workers of government agencies and counties who are being deducted every month, the money doesn't come. So you had a broke NHIF, unable to fulfill its liability. So that was the basic problem. Now, from there, you have now a new problem, as you have seen, the civil servant scheme. The civil servant scheme, if you look at the Auditor General's report, was a loss maker. Now, essentially, the Kenyan people, me and you, what we call Mama Mboga, the border people, they were the guys who pay 500 shillings. They were subsidizing ministries, departments, and agencies. Today, the Kenyan people don't owe NHIF anything. The people who owe NHIF is ministries, departments, and agencies. And until the National Treasury gets serious about remitting that money historically, that was deducted from civil servant salaries and county employees to SHA, then we cannot have settlement of historical debt.
Have there been any commitments whatsoever to clear this debt?
So one of the challenges we've had is a lot of public relations, engagement, announcements, pronouncements. We see it all the time. 3.7 billion shillings released, 1.3 billion shillings released. To be honest, there is a huge disconnect between the public pronouncements of payments. You know, a colleague was telling me today that they were in a meeting in the ministry, and they were told since the transition, 12 billion shillings have been released for payment of NHIF liabilities. And we find it totally incredible, because 12 billion is almost half the debt we are talking about. If 50% of the debt had been released since 1st of October, there would literally be no crisis. So the reality of the matter is they are commitments by word of mouth. They are pronouncements in media. These pronouncements are not reflected in bank balances. And if, and I am feeling very sad about this, if it is possible that this money is actually being released, we are curious. Who is getting this money? Who is being paid this money? Because if it is really being paid, then we are not getting it.
Look, today President William Ruto expressed optimism that whatever challenges that Kenyans are facing in this transition from NHIF to SHA will be sorted. These are just teething problems. Does that inspire some hope that perhaps things will get better in time?
No, I mean, if I was to tell the president, the reality of the matter is the two funds right now that have the most problem are the new funds that were introduced, that you introduced. The primary care fund, which is supposed to be appropriated by Parliament, where people are supposed to receive outpatient care. That fund is not working. Outpatient care in Kenya has collapsed. Emergency chronic and critical illness fund. You have seen cases of ICU bills going overboard. These two. So we are not today confident from what the president is saying that these are teething problems. This is what we'd say in Kiswahili, mwiba wa kujidunga.
Do you feel there is genuinely nothing good about the Social Health Authority?
Conceptually, as a concept, the idea that we can have three baskets, that we can have a primary healthcare fund to take care of level 2 and 3, that we can have a fund to take care of chronic, critical, and emergency conditions. That concept, that's a powerful concept. The idea that we can raise more money. Look, Kenyans, we accepted as professionals 2.75% on our pay slips. But when we met with the ministry during discussions, they promised us that this 2.75% will mean if you are admitted in ICU, you will be paid 44,420 shillings per day for 14 days. Today, yesterday we saw the PS release a statement that it is only 4,000 in level 6 hospital. We were promised 44,000. It is on the basis of 44,000 per day that we came out in the public and said, guys, SHA is good. Today we have reversals. So this is really, we need to be more honest. If you promised Kenyans palliative care, for example, chronic and critically ill patients, they say the Emergency Chronic and Critical Illness Fund will pay up to 700,000 per year. Why is it today that cancer patients who require palliative treatment are being reimbursed 3,360 shillings per day? Really? This is not a promise. So when we were meeting and discussing the benefits package, the story that we were told to accept higher taxes, higher contributions, was that your life is going to get better, you are going to get more benefits, outpatient care is going to be free for all Kenyans. Today what we are seeing, outpatient care, nobody can access outpatient care at level 4. The portal for level 4 facilities remains closed. What we are now hearing from providers is cartels emerging at SHA, which are telling them, hey, if you give me 250,000 shillings, I will open your level 4 portal. This is not the promise that we gave the Kenyan people.
So we're increasingly seeing more Kenyans paying out of pocket as essentially what was promised under the Social Health Authority, that is SHIF. So that is a completely different trajectory from what Kenyans really had anticipated. So look, with this growing dissatisfaction and you have financial strain on Mwananchi's side, on healthcare providers' side as well, what's at stake for Kenyans and stakeholders like yourself then?
I'm concerned. So as a healthcare provider representative, we have seen just this year alone about 15% of our previous members close shop. As I am seated here, I am concerned because we have 25% of our members who are in the small claims court. I am concerned that as we're seated here, 67% of private and FBO facilities have defaulted on their bank overdrafts. What we are looking at, literally, is unless there is honesty and focus, we are looking at total collapse of the healthcare system. I mean, if you combine the problems that we are facing as providers, and these problems, by the way, are very easy to solve. One of the things I must give credit to the team at SHA is they are willing to talk, but they do it like public participation. They invite you, you talk, goodbye, go. We are looking, if you combine, look at the doctor's strike coming up, look at what I am saying is happening to hospitals, and it's not private hospitals alone. It is private, public, and faith-based hospitals. We are definitely looking at collapse of the healthcare system unless there is a concerted effort to solve problems.
All right. Now, today clinical officers went out, they were protesting and they were raising concerns over the onboarding of 1,000 health facilities into the SHA system. We already have the ultimatum that has been given by the 7-day ultimatum by KMPDU. What does this mean for Kenyans when we're looking at the health sector, which is at the brink of a total collapse, if all this, all this is going on in the country right now? So
I think we are looking at an absolute failure of leadership. I cannot place this at the table of, let's say, the cabinet secretary or the PS. I think that one of the things that we have noticed is that a lot of these decisions are being made elsewhere. We noticed that MOH, Ministry of Health, literally, the technocrats at MOH are not at work. The decisions are handed over to them after they have been made. And I mean, it is good to have advisors. It's good to have, technocrats talking to the president. But there's a reason why you hire a minister, and there's a reason why you have a health department stacked with professionals from top to bottom. We think that the diagnosis here is nobody is listening. Really, everybody, I think the leadership is advising itself. We have been telling them from the beginning, we told them, SHA transition cannot happen in 3 months. Give us 2 years. They said, no, you guys don't want development. So now here we are. We are in this situation where the whole thing, the chickens have come home to roost.
But Dr. Rufa was part of the team that was there during the public participation. You agreed with the issues, I mean, you agreed with the transition to SHA. What has changed then?
It's a very good question. As I've told you, like all Kenyans, we analyzed the promises. We analyzed the narrative. And as I have said, I think having 3 baskets of funds is a great thing. The promise was that Parliament would appropriate 45 billion for primary care. What did they appropriate? 4.1 billion. The promise was that they would appropriate 50 billion for emergency, chronic and critical illness. What did they appropriate? 500 million. The promise was that ICU care would be reimbursable. Palliative care would be reimbursable. The promise was that you would not be turned away from a level 4 facility if you sought outpatient care. Is that what we are experiencing? So the reality of the matter is a lot of lip service and public participation being treated as a window dressing activity. As long as you show up, you are there, then we can tick that box that you are involved. But were you really listened to? No.
Things are completely different. What is the mental toll this is having on healthcare, healthcare staff?
It's incredible. I mean, one of the things we are seeing is a rise in mental illness. As you have seen, the number of cases this year of healthcare workers just, committing suicide. And that is the tip of the iceberg. A lot of healthcare workers in total depression. These are the people whom you are going to hospital with your own depression, hoping that they will help you. They are going through hell themselves. So we have hospital owners who have faced auction. I cannot tell you the number of people who call me, members of our association, telling me, Daktari, I am at the end of the rope. If we don't even receive even 50,000 this week, I don't know what I will do. My workers are on strike. I have people who are telling me that their employees are requesting them to sleep in the hospital because the landlords closed the houses. So can you convert one of the patient rooms? We will sleep here. This is not the kind of healthcare worker who you can trust a sick patient to. We do need to get serious about this problem.
Do you think Kenyans have also been shortchanged? I mean, promises were made, provision of ambulance evacuation services, emergency services, justifying why we have the 2.75% cut from our salaries.
I think that the government owes Kenyans to keep its word. For example, let me give you an example. We were told that if you are poor and vulnerable, and if you have no ability to pay, you will only pay 300 bob. Today, we are looking at means testing data that is going on around the country. Nobody's paying 300 bob. The very poor, at the basic minimum, are paying 450 to 700 shillings. So where is the truth when we said it will be 300 bob for the most vulnerable? When we were transitioning, 2 million Kenyans who were elderly, orphaned, widows, disabled, used to get paid for by the national government. Today, as we are seated here, nobody is thinking about our elderly people, our orphans, our widows, our disabled. County governments have abandoned the mission with the exception of a few counties where the governors are already doing means testing and already trying to onboard their people. Most counties are saying, we don't have the budget for this. So really, I think the reality of the matter is it needs to stop being lip service. Promises must be kept.
And it appears there's just outright lack of trust between healthcare providers and the government. How can we fix this?
It's not even only healthcare providers and government. Patients are telling us that we ask them, why are you not registering? They come to hospital and they're saying, no, just wait, I will pay cash. We ask patients, Kenyans, why are you not registering? And they told us, we don't trust the government. Kenyans told us themselves that we will not on board on SHA because we don't trust the government. So it's more than just us as healthcare providers. We have the advantage through our associations of interacting with the minister, with the team, the PS, the SHA leadership. So, we get some answers, but Kenyans are not getting answers. What they are getting is they go to hospital and they are told there are no drugs. They are told your name is not in a portal. They are told that, wait for the one-time PIN. Your surgery has not been pre-authorized. Kenyans are the only way to cure trust for Kenyans. It's very simple. If you want Kenyans to register for SHA, let Kenyans walk into a hospital and get care. Once they walk into a hospital and the drugs are there, the nurses are smiling, and their surgery is approved, you will not need to beg Kenyans to register. They will register in droves. So we restore trust by restoring service.
All right. And just very quickly, what do you think are the immediate actions that the government, the Ministry of Health, should undertake right now to stabilize the situation, because it appears the health sector in the country is truly in a mess at this point?
So, number one, the SHA is collecting much more money than NHIF ever collected. At 2.75%, we are sure SHA is collecting at least 7 to 8 billion per month. NHIF on a good day collected 5 billion. First thing, if you are collecting more money now, pay hospitals. Not only private hospitals. Government hospitals are collapsing because you haven't paid them. FBO hospitals are collapsing because you have not paid them. Pay them. Allow them to be liquid so that they can see patients. Number one, period. Patients don't need to know the details of our fight. Number two, we were promised that there was a consortium that was bringing us state-of-the-art portal, state-of-the-art technology. They, for God's sake, they even bought newspaper space and said they are bringing us technology. We are asking, seriously, if you are investing this money in Kenya and you are going to take money out of Kenya over 10 years, where is the technology and why are we not able to see patients because your technology has failed?
All right. Thank you, Dr. Brian Lishenga, the chairperson of the Rural Urban Private Hospitals Association of Kenya. Thank you for your time.
Thank you.
And thank you for engaging with us on this conversation.